Right now, just based off this being a 20. Get everybody
Okay, everyone.
Welcome to the Anatomy Equipment Lab and Training Center. Glad to have everybody here join us this evening. Tonight's webinar is going to be on the topic of unlocking the clinical application of shockwave therapy. My name is Jeff Rubinoff, and we have two amazing guests with us tonight. We'll introduce them here momentarily. I want to introduce colleague here.
I'm Joel Sirachi, owner of Regentix. Jeff is owner and partner in IRAD Sales Group, and we are here to demystify some of the rumors and legends about shockwave, bring out the actual science, and hopefully shed some light on this very complex modality that has amazing levels of efficacy, tons of evidence behind it, and is probably one of the fastest growing regenerative medicine modalities in the US. And of course, Europe was way ahead of us on this. So we're gonna introduce Alexander Ablas from Augsburg, Germany. Alex is a physiotherapist there and has been performing shockwave treatments for probably about 2 decades, maybe longer. I don't want to age him because he looks so young. And working with all of the professional sports teams as well as young adults for schools and things like that. Jeff, if you want to say some things about Alex.
Alex, so, Alex is going to go through science and clinical, the clinical efficacy, clinical use, focused on the radial shockwave. And when we bring Dr. Grove Higgins in, he's also going to talk about the science and clinical application of focal shockwave. So tonight you're going to get a very good mix of different technologies, application, the specific use case for each one of those technologies. And we believe that by the end of the hour with us, you'll have a very good understanding of how to kind of weed through all the noise that's out there right now in the space and differentiate science-backed technology versus marketing-backed technology, which there seems to be a lot of out there.
And feel free at any time during this webinar to type in your questions. We will get to them at the end of the webinar, and we'll make sure that all of them are answered. And of course, feel free at any time, whether you have a question or a comment, to type it in, and it will be displayed on our board here. So we will know that that question is waiting in the wings.
Yep. Perfect. So without further ado, we'll turn things over to Alex. If you want to give more of a little background to your clinic, the work that you do with athletes, and then kind of go from there would be amazing.
Okie doke, so let's start. Hello everybody from midnight Germany, and midnight very cold Germany already. You can see the slides. I want to start immediately about first introducing myself, explain a little bit more about myself, and then jump directly into radio shockwave background theory and cases. get you interested in our next event in November about hands-on sessions. So you get interested and probably come over and we meet in Miami and Sunrise. So first, some short introduction about myself. My name is Alex. I work with several professional teams in Germany. So first league hockey team and first league soccer team with all the youth academies in the background. I'm physio of the ATP Challenger Tour, most kinds in Germany and my region, and performing Shockwave, as Joe already said, for many years. So first, we will talk about theory because it's very important to know differences and basic backgrounds about shockwave therapy. We have got so many complicated devices on the market which are just not possible to perform the same things like others do, for example. Then, of course, I will show you interesting cases of my clinic and of a lot of athletes. Also, what else is possible performing shockwave? It's not all about just treating local issues. Yeah, we can perform a lot more by now, which we invented the last 5 and 6 years. And at the very end, a very important topic for me, networking and how shockwave basically opens different kinds of sports, athletes, and exciting events. So first, let's talk about theory. What basically is the theory of modern shockwave therapy? What can we achieve? We don't need no or less medication. We can avoid injections if necessary, such as cortisone. We can avoid surgeries. It's non-invasive. That's why we have a low risk level, and it's high effective. High effective means immediate results. At the very end, we get happy patients, and of course our practice becomes successful and well known in the region. We need to talk about the technology because in technology there lies the big difference. What basically is a shockwave? As you can see on the pictures, we're talking about acoustic waves. This is how a modern therapeutic shockwave actually looks like. We've got, in a very short rising time, high pressure, up to 100 megapascal of pressure. Then, after just 1 microsecond rising time, we already get to the phase, the tensile phase of negative pressure. Negative pressure is always around 1/10 of the maximum pressure. The bigger the negative phase, the more energy delivery we get in the tissue. The bigger the negative phase, the more cavitation bubbles we get. About cavitation, we will talk in a minute. So what is the principle of a radio shockwave? We call it ballistic generation. We've got a projectile inside the handpiece. This projectile gets accelerated up to 90 kilometers an hour, hits an applicator, and is converting kinetic energy into a shockwave, which is finally delivered into the tissue. This device has a penetration up to 4 centimeters. And this is how one of these radio shockwaves look like in action. You can see the wave leaving the applicator. This is just basically the measure instrument. What you can see is these tiny little black dots. These are the cavitation bubbles. These cavitation bubbles are generating the effect in our tissue. This has been found out already 24 years ago in this study. So at the very end of this presentation, you can get the whole presentation from Joel and Jeff. So that's why I put in these QR codes so you can read through all the studies which I present today and just make sure that everything is correct. So what actually is happening, cavitation bubbles and shockwave? So you can see in the very beginning, we have a cavitation bubble. By the increasing of pressure up to 100 megapascal, we get a compression phase of the cavitation bubbles. In the negative phase following, we get a release of all the energy out of this cavitation bubble. What happens when the next wave is hitting the cavitation bubbles from the first wave is we get a so-called jet stream and the bursting of the former cavitation bubbles. And this bursting and releasing of energy is causing different things in our tissue and finally causing results. When we talk about this releasing and about the energy delivery, basically what we can reach, we first need to make sure on almost all devices you can see bar pressure, the bar for pressure. This just means how much air pressure you put into a handpiece to generate a shockwave. It doesn't mean anything or say anything about the energy delivery, which basically comes out at the end of our handpiece. But this is basically what we want to know and what we need to achieve, high energy delivery. So some years ago, a very important study came out done by the University of Aachen in Germany. What you can see is a comparison of the two most important radio devices on the world market. First, on the left side, you see the Swiss dollar class shockwave device. On the right side, you see the Masterpulse 200 from Storz. So what you can see on the left side, we have got different bar settings. So different pressure what we put into our handpieces. And you can see by increasing the frequency, you can see our energy delivery. So the EMS device on the left side is maintaining the energy delivery at almost all frequencies by increasing the bar. Just in the highest setting here, it's dropping about 12% at the very end. If we change to the Storz Masterpulse 200 Ultra on the right side, we can see even with 5 bar pressure input in the handpiece and increasing the frequency, the energy delivery is dropping up to 90% in total. So what does it mean? Bar has no basic influence on the energy outcome if the handpiece is not proper able to convert this bar pressure input into releasing energy. You can see the red line. The red line is the average energy delivery in the tissue, which is needed in the main studies, which can be found in the Petro database, and where the shockwave therapy gets an effect which is leading to a perfect result. So we need at least the red baseline to achieve good results. And if you compare the devices, you can see that the right device is almost not able to even reach this baseline. Then, of course, we could say, what about just doubling the amount of impulses? And at the very end, we have the same added energy delivery in the tissue. This basically is a good idea, but in practical and theory, it's not working. The lower energy outcome cannot be compensated by increasing the total amount of impulses. We need every single shot count. So every single shot needs the high energy delivery. This baseline energy delivery, we need to reach it with every shot. So out of these studies, we know high energetic radio shockwave in comparison to low energetic radio shockwave is leading to better results. So, take-home message. Energy delivery is important. So whenever you talk to guys who want to sell you a device, ask for the energy which the device is delivering. And you will see there is a big difference. EMS, the inventors of radio shockwave, more than 25 years ago, know how this delivery actually works. And nobody so far can copy this technology. The comparison of cavitation in different handpieces looks like this. So we have a BTL device with 5 bar pressure input, 15 Hertz frequency. We have the EMS device. This is a focal device. And this is the Storz device. We forget about the Zimmer device because there just no cavitation is taking place. If we now compare these different handpieces, we can see the density of cavitation is the highest in the 2 EMS handpieces. But to be fair, we could say, okay, yes, there is something black and there is something black as well, so we should achieve a good result. Yes, but if you make the effort and count the cavitation bubbles, because we don't know how many cavitation bubbles actually lie over each other to create a black dot. So when we count all the cavitation bubbles, the difference becomes more clear. And we can see that the total amount of cavitation bubbles is just very, very low. What are the effects of shockwave therapy? Why are we actually performing shockwave? And this is, for me, this is quite important, one of the most important things, because when I know what shockwave is doing and what we can achieve in the tissue, then I basically have most of my indications for shockwave therapy treatments. So of course, patients want pain relief or elimination. So this is our first thing what we want to achieve, and this is something which is happening during the first treatment. Increase of blood circulation in the entire surrounding tissue. So the skin is turning red, increase of blood flow. Inhibition of inflammation. We need this point. Otherwise, the healing process can't start. Healing process like, for example, activation of reparative processes in the tissues, so as stem cell activation and growth factor release. And also muscle relaxing effect, like the pain relief. This is something our patients feel during one single treatment. So how does the pain relief work? Why is pain relief so important? You can see the chili pepper. This is how I explain the pain relief feeling to my patients. The transmitting substance for pain is substance P. So whenever in these injuries patients feel pain, substance P on C nerve fibers is leading to the pain feeling. And this is exactly what the hot chili pepper is doing. Hot chili peppers, not using substance P, but capsaicin, overwhelm the C nerve fibers, which are responsible for the pain transmitting, but then disables them for a certain period of time. And our patients have first a burning in their mouth, but then it goes numb. If you would now eat a more hot chili pepper, it burns again, and after a certain time, it goes numb again. If you would eat the first pepper again, it's not that burning anymore. And this is exactly what the shockwave is doing. When we activate the C nerve fibers, we get the release of substance P in the tissue where we treat, but also in the spinal cord. This prolonged activation of release, the C nerve fibers become incapable for some time of releasing substance P because we don't have so much substance P left. Therefore, we can't get the pain feeling. So first, we have the pain feeling and then recovery. Interesting connection is pain feeling and inflammation. The pain is leading to inflammation in the tissue. Inflammation is leading to pain feeling. So this is a self-stimulating mechanism. So we need to get rid of the pain feeling to decrease the inflammation. And this is exactly where the first step, where Shockwave starts. So again, we have less substance P, the pain feeling is going down. And because of that, also neurogenic inflammation is going down. When neurogenic inflammation is going down, we get a release of growth factors, activation of stem cells, increase of scleraxis, genetic expression. Scleraxis, just as a short saying, scleraxis we need in every phase of tendon repair. But then we can create proper healing. And the same is with the nervous system. What are our indications for shockwave therapy? These are the indications everybody knows. This is how it starts. Calcifying shoulder, Achilles tendinopathy, tennis elbow, heel spur, tendinopathy of the patella tendon. These are the basics, how it started. This is a list, just a short list of what I do in my daily work in my clinic. So this is also what we all talk about in the workshop, which we do in the beginning of November. Just work on these indications to understand how does it work and how can we achieve the best results. What else can we achieve? Some very important studies about shockwave. We can improve blood supply, which means we can increase the forming of new capillaries. Important for wound management, like bad healing wounds, but of course for ED. Erectile dysfunction becomes more and more important in everyday's life. So we get a lot of patients suffering from this, and this is a really good way of actually helping them. And it doesn't matter if you use the radial or the focal device. This is a very good way of helping these patients. So we need to mention this. There are good studies, and of course we need to show how basically this kind of treatment works. We can stimulate new bone formation. This is one of my favorite topics. Yeah, fracture healing. You will see some cases at the end of my talk. And even when we have regions with increased fracture risk, like osteoporosis, it's a possible clinical indication. So we need to clear our mind thinking that we use a shockwave like a hammer. I said in the very beginning, it's an acoustic wave. So basically we are screaming, not hammering. So don't be afraid in destroying osteoporosis, bones or whatever. Just some studies to have a review at the very end. Osteoarthritis of the knee. Why does it work? It's again for understanding how shockwave works. What is the problem with osteoarthritis? We've got pain and inflammation. This is where it starts. Or arthrosis. Yeah, we're not curing arthrosis, but arthrosis itself, it's not causing the pain feeling. It's the inflammation which is causing the pain. Tissue inflammation, tissue pain. This is why it works perfectly. Let me show you some case reports, because just make it clear. The protocols you will see there are just individual protocols for this every patient in these cases. Yeah, let me say something about the basic way to treat. A general protocol for me is set up strong device, highest frequency. I showed you before in the study, we can maintain high energy delivery at all frequencies. So why not use the highest frequency to deliver as much energy as possible? The more energy I deliver, the more cavitation I have, the more effect I have in the tissue. Then how many impulses do I use? In general, between 3,000 and 5,000. In the cases you will see 1-2 difference where we definitely need more, but 3,000 to 5,000 impulses is a rough number for radial shockwave to apply. or to make it easier, how many impulses do I use? As many that our patient feels better. Then the most important question, how much pressure do I put in the tissue? And the simple answer is 6, that my patient feels pain, 6, 7 out of 10. Individual pain threshold of our patient. This is what we need. Shockwave therapy needs to be painful. If we are not creating pain, it's a not effective treatment. So let's jump into the cases. First, of course, with my athletes, one of the most important injuries, muscle injuries. And I don't care if it's a strain, a fiber rupture, a bundle tear, or whatever. We start always the same way. There is a nice study which has been done with a first league team in Germany. They treated all muscle injuries just with Shockwave and a special training. You can read this in the study. What you can see on the right side is this is how muscle behaves when you just treat it with radial shockwave or focus shockwave. You see the fluid, you see what happens within 10 days. This is how it works. Fractures. One of my favorite topics, I already mentioned it. Jones fracture, it's one of the most common fractures. I use the shockwave because we always have the situation that in the fractured area, we have a really bad blood supply, which is causing very often non-unions. I prefer using a screw during the surgery because then I have the opportunity to use the shockwave all around the fractured area because I can't penetrate metal implants or metal plates, which sometimes get to this surgery points. So I like screws. Start immediately. First day in hospital, we use manual lymphatic drainage and some different cooling devices, but from day 2 onwards, we start using the shockwave. First, pain relief, lymphatic drainage, and cooling at the very end. This is what we want: inflammation, pain, and swelling. This is what we do in the first way. Then we always increase the power to our pain threshold. You can see we're already day 11 changing to the smaller applicator to concentrate more energy on smaller spots. Stitches are still inside, yeah? But no swelling, no pain. Yeah? Patients get a bit bored because they want to do more, so we can let them walk in our anti-gravity treadmill. And at the very end, we don't have a risk or we don't get non-unions in these fractures. Also, if it's getting worse, like a friend of mine, was one of my soccer players, severe ankle trauma. So you can see ankle distortion trauma, fibula tibia fracture, syndesmosis rupture, front and rear. This is 5 days after the surgery when he came for the first treatment. This is one of the cases I mentioned. 5,000 impulses are definitely not enough for this. It's about 15, 20,000 impulses first treatment on the whole foot for drainage, for pain relief, etc. But what you can see is this is happening within 2 days and this is happening within 5 days. So you can see enormous decrease of swelling. Even if these fractures don't heal, we know out of these 2 perfect studies that we can treat delayed fracture healing and non-unions. We don't even need a focus shockwave to concentrate highest energy. We can treat them with both radial and focal. Delayed fracture healing. This is how a bone can look after 6 weeks after a planned surgery. 5 combined treatments. You can see already increasing of bone healing, and another 5 treatments, and we know now this bone is proper healing. Or if it's even worse, like this rheumatic arthrosis of the fibula, 8 months after the surgery, 10 treatments within 4 months with the focused and the radial device, and you can see a proper healed bone. Ligament ruptures, exactly the same. First league soccer player, we can see the ATFL rupture in the ultrasound. Acute treatment, we use like using a high power laser and cryotherapy, but already after 12 hours latest, we start using laser and shockwave and cryotherapy. We know cryotherapy is very important after shockwave, very important after shockwave, because it's increasing our results. After 24 hours, these patients usually can walk with full load and no swelling, no pain, which is important just to stay in an alignment. After, in the MRI, you can see the rupture, but you see there is no joint effusion. This is how it looks like. Usually these players or these patients come with a swelling. Here in the second picture, we already used a 50 millimeter tip on the ruptured area, and this is one way of hyperbaric CO2 cooling device, which we most likely use at this punctural treatments. And then these players have total downtimes between 14, 21 days, fully taped. They can go back on the pitch. Increase of blood flow and decrease of swelling. This is something we can actually see. Yeah, this is before and after the treatment. So this player came with a huge swelling. We did the treatment, and directly afterwards it looks like this. And we can make these things visual if you want. So this is an ACL rupture after surgery. We did a shockwave. On the right side, you can see how the blood vessels start to work. Another one. Yeah, you can see the changing and how these blood vessels start to work, and it's visible. We can see it. We can see how these vessels start to work during the treatment. Schlatter disease. I know this is not a Schlatter disease, but I like the picture. Schlatter disease, very common with growing children doing a lot of high intensity sports. We need to get these kids as early as possible to do shockwave treatment. We need to avoid to hit the growth plates in this position directly on the tuberositas. We don't hit the growth plates. We don't have any problems. You can use a laser before if it's too painful. Otherwise, we just start doing the shockwave and the cooling device afterwards. These high painful kids need, at least when you start early, 3 treatments. And you just need to decrease the load which they have in their daily activity, in their sports, to get them back on the pitch, on the field as soon as possible. Bursitis capsulitis. This was a professional cyclist. He was suffering from an elbow spur, and this elbow spur caused an inflammation of, and it was causing a bursitis. Now it's again the same thing. What do we have? Pain and inflammation and swelling. So this is where the shockwave starts in the very beginning. And then after 4 treatments, no swelling, no pain, no inflammation anymore. Chronic polyarthritis was a friend of my mother, 16 years. This wife, a woman was taking painkillers 28 years. 28 years. Several deformations of the hand, which you can see in the first picture in a minute. And then we did the treatment. 15 days, 5 treatments. And this was how it developed, how color, swelling, and everything changed. Of course, we can't cure the polyarthritis, but she is coming now every 4 to 8 weeks, depending on how much she's doing, how the inflammation situation is, gets another 1, sometimes 2 treatments, and it stays in this situation. Now, I promise you to get you more excited about attending our practical 2-day lecture in November. Now you saw a lot of cases where we treated the injured area. Now I want to show you what else is possible, and this is just the beginning. This is a young hockey goalkeeper after hip surgery. You see the difference in hip mobility on the left side, decrease of external rotation, very painful, 7 out of 10. And what we do is just applying a short shockwave, 3,000 impulses, 2.5 depending on the patient, below the inner malleolus, as you can see on these pictures, to get an influence on the whole kinetic chain. And what you can see, or what the patients feel directly afterwards, is increase of mobility and flexibility, decrease of pain. So the whole kinetic chain is releasing, the pain score is going down, and this is something we can perform upper body, thoracic spine, cervical spine, lumbar spine, rotation, elbows, shoulder, whatever. And this is something really exciting because you can not just cure problems by local treatments, you can just solve problems caused by a kinetic chain problem. So I hope you get excited now, and we'll see us in November. One of the most important things for me, that's why I'm staying awake until midnight, is networking, sharing knowledge, exchanging knowledge, because I don't know everything. I need you as well. Do Shockwave, try to find out things, play with kinetic chains and whatever, and then exchange it, feedback. We have a huge network spread around all over the world. This on the left side, bottom line, is just the German team, consisting of a lot of team doctors and physios of several first league soccer teams. This is what I said before. This is just the excitement, what you can achieve, not just by, but this is what happens just because of Shockwave. Yeah, meeting professional athletes, achieving very great results at the very end. As you can see, this guy just comes from Florida for treatments, and this basically was for me a highlight in my career. Yeah, just a few months ago, I had the honor of drinking Aperol Spritz out of the Stanley Cup. Yeah. This is the inventor of Shockwave, in my opinion. I think a lot of competitors don't agree with me. This is a very old 1-bar device with 1 Hertz frequency, probably 2 Hertz frequency. I must say, I'm very happy that I don't need to do Shockwave like this. I'm very happy that I can do Shockwave the way I'm doing it right now. A very old Roman guy said once, to recover, you need to suffer pain. This is how I come back to what I said in the very beginning. If Shockwave is not painful, it's not working. If one of you is a bit scared of using Shockwave device in so many ways, like I just presented, I want to give you a short look on the right picture of this guy. He's a first league player. He was, after hip surgery, he was in my clinic, and this is what he's doing as the second treatment on his thigh. So he just copied what I did. I was talking in the front desk to my ladies and then heard the noise of the Shockwave out of my room and just went back and saw him just doing Shockwave on his own. So he just copied what I did one day before. If we agree that soccer players are usually not the brightest candles on the cake, I think nobody needs to be scared of doing Shockwave. To come to my end now, again, I want to invite you to meet with me in November. I'm really looking forward to do this practical stuff with you. If you have questions, also within the next days or during the next weeks, don't hesitate to contact Joel. He will pass over my email or Instagram or whatever. Ask the questions, feel free to ask. Sometimes it takes a few hours, but basically I try to answer as soon as possible. And yeah, Now enjoy the focal part with Dr. Grove Higgins, because it will be amazing.
That was awesome, Alex. Good job.
Thank you, Alex.
Good job. That's a lot of information, a lot of science that you dug into, and it's going to allow Dr. Higgins really to kind of springboard off of that and tie in some of the data and information on how, you know, vocal and radio work in tandem together. But before we kind of turn this over to Dr. Higgins, there are a couple questions we want to get to. Also want to just, you mentioned the workshop that's coming up, and want to highlight that as well. So November 7th and 8th, that's right around the corner, Unlocking the Power of Shockwave Therapy. This is an amazing session. You guys saw some of it in the video that we played in the beginning, and you'll be able to meet both Alex and Grove in person here at our great training center in Sunrise, Florida.
And we will also have on hand Ken Johnson from Johns Hopkins. He's the executive director of the ambulatory rehabilitation program. Ashley Campbell as well, owner of Performance One, and from TOA in Tennessee Orthopedic Alliance, and Dr. Perry Camissa from Ultimate Chiro Care. These guys give the absolute best hands-on workshop in Shockwave. I promise you, there is no other course in the United States, and even some of the workshops that go on in Europe don't get as deep as these guys get. And I see questions on, and we'll get to all the questions, but someone mentioned kinetic chain, fascia. These are the things that you will learn in this workshop in a 2-day hands-on with the best trainers in the world. Absolutely. Again, November 7th and 8th, that will be here in Sunrise, Florida. Go to anatomy, ANATOME, lab.com, and you guys can sign up there, and I can promise you this will be one of the best courses you've ever taken in Shockwave, hands down. A couple of questions that maybe both of you can answer before we go into Grove's talk on focal. What are the ones that were above that one there? If you can scroll up. So I think this applies to both focal and radial. So both of you can answer this, and I already know what the answer is going to be, but Janie Ellie, I think I'm saying her last name right. Janie, sorry if I'm not pronouncing it right. What is the maximum pulses per session? You can see it there. And maximum body areas per session that you've done? We've gotten this question before, and providers have always been curious as obviously maximum number of pulses, which obviously is going to relate to the area that's treating, but is it too much to treat an ankle, a hip, a shoulder, and a wrist all in the same session, or is that fine, etc.? Like, what are your thoughts on this, Alex, in regards to radial, and then Grove in regards to focal?
Right.
It basically doesn't matter. It just depends how much money the patient is willing to pay. But basically, it doesn't matter if you treat an ankle, if you treat a kinetic chain, if you treat the shoulder or the elbow. It's just about time, money, etc. You can't overdose it. I wouldn't treat one area twice a day. Yeah, this doesn't make sense because the body needs time to react on what you're doing. But basically, to treat several parts in the body, you don't have a problem.
And Grove, do you concur?
Yeah, I can concur with that. And really, the number of pulses depends on the area that you're treating. The smaller the area, the fewer the pulses, and the faster the time, typically, right?
Right.
Treated with a gentleman with bilateral lower extremity neuropathy from the knee down. So it took 8,000 pulses in total, but I'm treating calf and posterior lower leg and anterior and his
Right,
foot.
you're not sitting on one anatomical location.
Yeah.
And would you guys say, is there a maximum that you remember ever going to on a particular treatment or session? Anything crazy?
I think the highest number was radial 24,000 or something.
Wow.
24,000.
That's a lot.
Huge swelling after an accident, both legs. So this is definitely something you need a huge amount. But as I said before, basically there is no limit. There is no limit. It just doesn't make sense if you apply 20,000 impulses on a calf and you don't get a result, then probably it's the wrong indication. The device is broken or just a not working device, or the problem is somewhere else. Yeah. So usually you should reach the result a lot earlier.
Right.
This is a great question. I already know the answer to this one, but I'll let you guys refer to it. Is it okay to use over fractures that have hardware and screws? This provider, I believe, was misled and told to avoid hardware, especially newer hardware. But again, Shockwave is not electrical. It's not high-powered cavitation. So I'll let you guys complete that.
Yeah.
Grove, you want to?
Agreed. You can use over hardware. I've used over, like Alex was showing us, with screws and other hardware, knee replacements, hip replacements, to help speed the healing and the acceptance of the implement into the body. And it works exceptionally well. Yeah, you're not generating heat. You're not conducting any electromagnetic waves into the area. So there's no danger there.
Right. I mean,
literature is quite clear about this. Yeah. So it's exactly the other way around. So everybody who says it's not allowed, it's just they don't know it better.
Yeah, I mean, clearly you wouldn't use it near a pacemaker, over a pregnant belly. You want to stay away from the lungs in certain situations. So that
right.
But electronic devices would be affected, but not hardware, not surgical metal and things like that.
Correct.
Last question we'll do before we move on to Grove. How many sessions would you do on a fracture? 6 or more?
More.
Yeah.
Especially when you've got an elderly individual that has like a fracture, Jones type fracture. Those are slow healing and are susceptible to shear forces after the person starts to put pressure through them again. And so the Shockwave is exceptionally helpful to that. But because of the older individual with poor blood flow and just slower healing and recovery in general, it takes more.
Yeah.
Would you guys follow out? I mean, obviously with tendons, it's very easy for us to whip out the ultrasound, take a scan, and see what's happening as far as progress goes. If someone has obviously X-ray in their office, would you guys have an X-ray done at 1 month, like at every 4 weeks, to see the progress of the healing, or is that overkill and just wait till the 3-month mark? What would you recommend on that?
I don't have it in my office, but I encourage the patient to go back, of course, at their regular visit, that their follow-up visit that they're supposed to have. But then I'll have them go back at 3 months and redo imaging just to show it, and as much for the patient's edification and satisfaction, as much as wanting to know myself how complete the healing has been.
Totally agree.
And one last question for both of you, because I think this is an important one, since we were talking about not going over certain areas. And we can answer this both for radial and focal. Do you avoid the thoracic region because of the lungs?
No.
So basically, what do you do when you're near lung tissue? Obviously, there's depth control. There's certain things that you're doing, but can you guys touch on that a bit, and then we'll let Alex go sleepy time, and we'll go.
Yeah, mine's real quick. It's depth and the amount of energy, and then working with the patient to get subjective feedback and looking for signs and symptoms of any kind of negative response or reaction, like coughing, a tickly throat, even sometimes. Those types of things. Otherwise, there's a lot to treat around the thoracic cavity.
Oh yeah.
We know by now that it's even really important to treat this thoracic area for example, COPD patients. After COVID, it's highly important to use Shockwave in this area, so we can increase lung capacity, the whole thoracic mobility. So like I said with the hardware stuff, yeah, it's the other way around. We are even increasing the lung function by using shockwave in these areas.
Excellent.
Perfect.
Thank you guys.
That's great.
Some great answers. Alex, thank you so much. We can't wait to see you November 7th and 8th. And I'm sure the students are amped up as well. And stay safe, man. And we'll see you soon.
See you soon.
See you soon. Nice evening. Thank you for everything, Grove. Good lecture again.
Look forward to seeing you in a few weeks.
Definitely. Have a good evening. Bye-bye.
Thanks, buddy.
Thanks, Alex.
All right, everyone, we're going to bring in Grove Higgins, owner of Neuroathlete and Chiropractic in Colorado. And Grove is going to talk about focal shockwave. Grove has been doing shockwave, I believe, for almost over a decade. Is that correct?
I'm right at that threshold, yes.
Right at that threshold. And Grove does shockwave almost on a daily basis and with many, many patients. So he's probably got the experience level of some providers who've been doing it for longer, but just haven't done it as much as he has. And Grove is extremely skilled in the musculoskeletal application area. So we're going to let Grove take it from here and do his thing.
Excellent, excellent. Yep, let me pull up the slides there for you guys.
And again, anyone has questions, we have all your questions. We will get to them by the end. And at the end, we will also share them with Alex and Grove via email so that you guys can get some more direct answers. But we will address all the questions by the end of the webinar.
Right.
Yeah, definitely. So nice to see everybody there. Yeah, no, this has been this is the only device that I had in my clinic for many years. I've added to it, but all those times before I was using my hands predominantly. And until Shockwave came in, I had a patient who was interested in Shockwave for an ED problem and had me investigate it. I reached out to a company. They came out, brought me a device, and within 1 month, I did 100 treatments on patients and was able to get results that my hands were not, both between manual soft tissue as well as joint manipulation. And it was astounding. And I happened to have dislocated my shoulder that same year myself. And so one day I brought the machine home with me and ended up waking up in the middle of the night with the shoulder aching and treated myself. And from that day, that night, with about 10 minutes worth of work, I have not had pain in it so far. And I know I tore my long head biceps in that injury. So one way or the other, it is a highly, highly effective device that I use and I have patients ask for now. And so I enjoy it a great deal. Sorry, I've got the wrong screen up for you guys. Let me share the right screen. I think. Sorry.
We're here to share it as you go. But while you're looking for that,
Yeah.
There was a question that came up, and I know
Yes.
we kind of went over and answered it already, but it was so the question here was from Janie. If a patient has 5 areas that need shockwave, for example, can all those areas be treated on the same day? And we kind of covered that, and the answer was yes. And you agree with that as well, right?
Yeah, no, 100%. Yeah, it's limited by the amount of time that you've got and what you want to accomplish in that visit. That's really what it comes down to.
And I would say, probably some of these questions come from the mind frame in platelet-rich plasma, for instance. We try not to treat too many areas at once because we don't want to overload things. And also because if you treat 2 knees on a patient, two knees with PRP, that patient's going to have a tough time walking. Shockwave is almost the opposite because there's this instantaneous pain relief. And because of rehydration of extracellular matrix, there's this restoration of flexibility and function. So I'm guessing it would be okay to treat a patient bilaterally on the same day, like bilateral knees, bilateral ankles. Like, what would you say to that?
Oh, most definitely. Yeah, most
Okay.
definitely. In fact, if somebody's coming in and they're hobbling around because they have a problem on both sides, and you leave the one side causing them to compensate, they're going to slow down the recovery.
Gotcha. Okay.
Point.
Thank you.
That makes sense. Okay. All right. Fantastic. Okay. Good. All right. We're up and going now. So just a little bit more, just because I think it's really important to understand what's really being affected by the shockwave. So we have these stimulations of various different cells within the body and release of different inflammatory markers, TGF, VGF, which is vascular epithelial growth factor, which is the primary growth factor that excites the growth of new blood vessels into that area. So especially in chronic areas like chronic fibrotic tissue and such, one of the things that holds up that tissue from being able to improve is the fact that the blood flow is so poor. And so being able to influence the growth of blood vessels into that area, bringing oxygen, helps to influence the reformation of that scar tissue into usable tissue. And to that end, working with individuals who are doing regenerative medicine, this is one of the mechanisms that is highly sought after, especially when you're working with somebody that's having a large amount of scar tissue built up and needs that scar tissue to become better ligament tissue, better intra-articular tissues and such. And you've got an older individual that has poor blood flow. This is the primary, one of the primary mechanisms here that helps that tissue to mature properly. But we can see here, this example is for tendinosis, but we have this evolution of tissues to become the type 3 collagen, to become the tissues that the individual needs. And so this is really exciting, and a lot of regenerative medicine doctors now are utilizing this as a non-biologic, orthobiologic of sorts in their practices. So for myself as a chiropractor, this helps link me into them. I'm going to skip some of the science here for you. Again, a little bit of a timeline on what happens after shockwave. So you have that immediate release of substance P, pain modulation, inflammatory mediators, and hydration of tissues that occurs. Within 24 to 72 hours, we can still detect NO2 release and a vascular response, a relaxation of the vessels and an increase in blood flow into that area. And even within days and weeks, we can, after just a few treatments, we can see collagen remodeling and proliferation of things like tenocytes. And then down the road, we can see continued return of function and faster tissue regeneration. So it's important to the patient. All right. So like Alex was already saying, we could treat a multitude of things, acute and chronic pain problems, repetitive motion injuries, which the large part of the problem there is that hypoxic fibrosis that's occurring in there, and reversing that environmental problem that is preventing that tissue from becoming healthy again. Acute injuries, like Alex was saying, it's fantastic as soon as the injury occurs to help the tissue to recover, but then also to help get the patient, the athlete, back on their feet rapidly. Trigger points recovery, and then again, the regenerative medicine component here. So some real basic things. I'll just expand on some of what Alex was saying here. We're looking at mechanotransduction is really the key factor of what is making the change in the human body. And so those sound waves create compression of the molecules ahead of them and creates a pressure wave. Right? The difference between radial and focal is pretty profound. The mechanisms can be fairly similar. In radial, the highest pressures are derived at the treatment head. So where the modality, the machine head is contacting the skin, that's where the highest pressure is. And then the pressure waves propagate down into the tissue and, of course, towards the target tissue. Whereas in a focal device, those pressure waves are focused down to a point at a precise point within the body, within the tissue, where then the shock wave is propagated at that depth, 1 centimeter, 10 millimeters, whatever it is. And then you still have a bleed over of pressure waves beyond that. So the difference between the two methods is pretty profound. So in radial, again, as Alex said, the bullet is shot to the end, the mechanical force is delivered to the head of the device. That acoustic impulse travels through from the shock wave at the skin through the tissue, and you get the biological effects as it goes through the tissue that you are aiming at. Versus in focal, where those pressure waves are concentrated down into the shock wave, so we can deliver that shock wave, we can deliver that energy specific to the tissue at depth and create the highest energy possible at the target tissue on the lesion and create the biological effect there. And then we still get biological effects beyond that target tissue. To demonstrate that, Mike McCafflin, one of the many people that I get to work with over the years, he and his son did this little video for us, and I just got it. So what you're seeing here, you're seeing the propagation of those bubbles, those cavitation bubbles that Alex was talking about in this zone right here. And that's really the most important and the most effective area of treatment because that's where the highest energy is occurring, right? So in this case, that head on the piezo wave is at 20 millimeters. That's a 20 millimeter head. And so the majority of the energy is being delivered at that 20 millimeters, 2 centimeters point. You saw this with Alex as well, that this is a shock wave, right? This is where the highest energy is delivered, and then there's a bleed off and that negative pressure wave that he was talking about there. This is the shock wave. This is the maximum amount of pressure, the maximum amount of energy that can be delivered, versus a pressure wave where you have the maximal amount of energy being delivered, its maximal negative response, its recovery, its refraction, and then as it goes deeper into the tissue, it decreases exponentially as it goes through the tissue. So what affects shockwave transmission? Well, tissue density and composition. The more liquid the tissue is, say like muscle, the pressure waves travel further, longer, and maintain more energy because there's less density in there versus in things like bone and tendon tissues where the density is much higher and the liquid component is much lower. Acoustic impedance mismatch, basically that there's differences in densities and that causes refraction of the pressure wave. Energy flux density, which Alex already talked about, it has to overcome that dampening effect of the tissues on top. Skin's pretty thick, right? And the fat that's right there before it gets into the muscle. Frequency and rise of time, which we just saw on the chart, and then the angle of application. So if we want to get to that Osgood-Schlatters lesion, 90 degrees is better. But if you're looking at a lesion that is fairly shallow and you're using the same tissue or the same treatment head, you can angle it to create a longer distance so you can, again, deliver energy precisely to the lesion that you need, depending on the patient's morphology, and what your end goal is. All right. So here's where we get a difference here. This is a focal shockwave. These are pressure waves, again, that are being sent out from the treatment head to a point into the tissue where the shockwave is being delivered. This is about a 1 centimeter point in front of the treatment head, and this is a focal of in this particular format. This is the focal head of the focal device. There's a broader head, so it allows you to treat more at the same time. But that ball of energy right there is where the most energy is being delivered. In the piezoelectric situation, that is a very evenly derived and delivered amount of energy, versus other devices that are out there which use electrohydraulic or electromagnetic, where it is not really a true focused wave. There's a bleed out of energy, and it's a refocusing of energy in order to get the amount of energy that you're looking to deliver to the tissue. And in the piezoelectric situation, what's happening is that there's a crystal that is being charged and discharged, and that causes the effect of a pressure wave, a sound wave that is then going into the body to create the shock wave. The benefit here is that this mechanical force here is very efficient, and thus the treatment head can last into the tens of millions of pulses, versus most of the other ones like the electrohydraulic and magnetic. They burn out very quickly. Some of them within less than tens of thousands of pulses, and others at just a couple of million pulses. And then the replacements are extremely expensive, and you have downtime, of course, for use of the machine. So again, just looking at that, where the focused amount of energy is right there. All right. So, and again, this here is just looking at the amount of energy that's being delivered at any depth. So the focal being this blue dashed line here, the amount of energy, if you pick at a certain depth, will be delivered at that depth no matter what. And right now the machine, the piezo machine, has the ability to deliver energy up to 3 centimeters specifically, but we get bleed over all the way to 4 centimeters, and then pressure waves beyond that. Versus in a radial shock wave, your effective dosing, and that green line is the biological threshold that it responds to, at about 1 centimeter and such. But there are pressure waves that are going into the body that are still creating a physiological effect. So like for the broken femur that he showed in one of his images. So here's another aspect of what is attractive to me about focal, and I have used radial as well. Radial is very fast in the ability to cover large, broad areas of tissue, which is really helpful for a busy clinic. But for the specific things that I end up treating, I use focal quite often. We can consider it a true shock wave occurring in the body. So where those bubbles are occurring, it's happening there, and we can deliver a higher amount of energy there. The important part one of the important parts for me is, what is it doing in the joint? So in a radial scenario, those pressure waves are going out, and so as they're going out, not all of them are coming into the joint. So say like a meniscus, or if we're looking to treat chondral tissues and such, you're getting incidental energy into the joint rather than directed energy into the joint, because the shock wave is occurring at the skin level, and it's only going to travel so far effectively in this case. Versus a focal shock wave, where those pressure waves creating the shock wave can be directed right at the tissue joint interface, and we can deliver much more energy into the joint. And the joint being larger, say like a knee and meniscus, we can deliver a lot of energy into the joint very specifically. And here's just a case study. This is a rodent model. But what has happened here, we have two different models here. This is a surgically induced meniscal tear. So a surgically simulated meniscal tear in both cases. This one actually, the one that has the application of Shockwave, is actually, I think, much worse. But then they histologically pursued it. This is one treatment. And after one treatment, after 4 weeks, you see a change in the tissue. So where there's still a gap here, there's still a gap here, but the gap here is much more filled in. You can see that that surgical tear was a complete tear. And now we have overlapping tissues here. And at 8 weeks, you have complete healing, essentially, of that meniscus in the Shockwave application one versus a degenerative meniscus after 8 weeks without. And that was with one treatment. So when you're working with joints, you have to consider things like depth, knee, trying to get into the joint versus, say, like spine, lumbar. So can you deliver at a precise amount of energy to the tissue, target tissue, precisely, so you can get precise results? So some of the clinical decisions that you have to choose when you're choosing which machine to use for what, and they overlap quite a bit, is, what are you treating and what's going to help you, right? So chiropractors, of course, we're looking at myofascial problems and trigger points quite a bit. Some of those can be extremely deep and can be very precise. Within a physical therapy setting, we have a lot of, again, overlap as well, tendon, fascia, and we need to cover a larger amount of area potentially. And depth is important, but sometimes maybe not the most important. Or like in a regenerative medicine scenario, are you trying to enhance cellular environment for a inculturation and maturation of cells into that joint? Or are you looking at just reducing pain because you're a pain clinic and tissue healing is a secondary consideration? When you guys get these, when you get the slides, you can look at some of the decision-making matrix that I've created here for you for looking at which device, which modality to use for which problems. As it goes to some, I know we're way over time tonight, some case studies. I've got a few here for you. Just real quick, 15-year-old male with had bilateral posterior shin splints, had not finished a soccer season, and he's a very high level now pro player who had not finished a season in over 2 years. As he went through his season, his rest would not be as high, so his pain would be growing through the practice season and into the play season, and he'd eventually have to beg out. But he was one of their top players, so they played him as much as they could in the short time that they had him each time. It was diagnosed via MRI. He went through many different therapies and bootings and injections and such. In the end, I'm going to move to the treatment here. I saw him at this date with just one treatment, so 8,000 pulses between, or 8,000 pulses each leg, because I went to various depths for the individual. I was going for just the analgesic response, the pain resolution response, and did, of course, a little follow-up training with him beyond that. After the first treatment, we had 80% resolution on a shin that was unwalkable. He walked out with 80% of his pain resolved. By the third treatment, he was 100% pain-free. Of course, he was asking if he could return to play. So after 2 weeks, I had him go back to his trainer and get cleared for return to play. And he continued on with me for a while. That treatment, that one case was easy to resolve. It was a young individual, but it was worth quite a bit of money for me, and he comes back to see me today for other problems. And of course, yeah, his entire family came to see me after that. And then a 41-year-old male, and his problem was injury from neck injury from wrestling and stepping off of a tailgate, and in this case, the neck injury was a secondary problem, but he had a joint injury, again, a meniscus injury. We went, and within 3 days, again, less than 80% of his pain, and by the end of February, he was healed, and that's the approximate value of that particular patient there for you. As Alex said, the idea of having a highly networkable device that allows you to talk to a lot of individuals is important. This generates conversation amongst patients. They're now looking for it because there's a lot of companies out there in the marketplace, but they oftentimes are failing. And even like around my location here, within walking distance, there's 2 other Shockwave devices, and I have patients coming from them, and I have their practitioners sending patients to me for the specific treatment that I can, with my device, deliver that they can't with their device, and their device has better marketing. I'll just put it that way. But the piezo wave has been an extremely important part of my practice, and why people come to see me now.
On that note, what would you say the primary differentiator would be that the piezo wave stands out? To your point, where a provider has, what they think is a Shockwave device, but yet they're not getting the outcome.
Yeah. So what the big differentiator is that I have a lot more control of the dose, the depth, and of the treatment, and that allows me to get very specific results. I don't have diagnostic ultrasound in my clinic. Joel, I'm going to be talking to you about that, and even with my imprecise selection of depth, I think the big differentiator there is because I can target the lesion specifically, I get much greater results because of that.
Mm-hmm.
Yeah, and proper Shockwave devices really have that diagnostic aspect where if you're on healthy tissue, patient's not really going to feel anything. And when you hit that pathology, they will say right away, that echoes exactly my pain when I'm suffering, and you're in the right area.
Well, and thanks for bringing that up. The diagnostic aspect of using a focal device that allows you to mediate the amount of energy that's going in, allows you to do better diagnostics. I'll give you an example. You have that individual that comes in with elbow pain, and as you are trying to find the right location and start to dial in the depth, you can find lots of potential different concomitants. So other parts of that problem. How much elbow pain comes from the shoulder, right? Whether it be something like a biceps tendon or a rotator cuff tendon pathology. And in being able to target the area that the patient was concerned about, you find the other parts of the problem that are actually the bigger drivers. The big differential there between a radial device versus a focal device in that situation is that the radial device creates its highest amount of energy at the tissue machine interface. And that's where the highest number of nociceptors are. So as that shockwave hits the skin, pain is increased. There's too much feedback. The patient can't find and can't feel the concomitants because the area where the application is being applied is so overwhelming sensory-wise. Versus focal, where we can get depth, we can adjust very precisely the amount of energy, and we can look for radiations, we can look for referrals, and thus do a much better job of diagnosing. This is where having two different devices is much more superior than potentially of having one. But if you have to have one, what are you trying to do? Are you trying to diagnose problems specifically and get those results?
Yeah, and then how would you attribute that to depth of penetration as well?
Yeah, oh, most definitely. Again, going back to the discussion on joints, if the joint is the focus, I need to get as much energy into that joint as I can, so that way I can get the same results the rat got, at least for my patient, and that I'm getting for my patients. And even though there's not a lot of human research on meniscal repair, for example, we're seeing it in the clinic all the time.
Yeah. And to that point, I mean, a lot of our providers that use both radial and focal, there's strengths of both of them and weaknesses in both of them. And that's why there's this overlap. Obviously, radial is more superficial, but you can hit these large muscle groups and bring blood flow in that kinetic chain while treating the pathology with the focal and hitting like an Achilles or something after you've hit the calf, the hamstrings with the radial, and then you treat the pathology with the focal. So you're releasing the kinetic chain, maybe releasing some fascial issues, and then you've got this excellent overlap. To that point, I want to bring in a quick question that's related to what we were just saying. Monica Lianage, I probably said her last name wrong again. I'm mutilating everyone's last name tonight, but she said, which one is less painful, focal or radial? And obviously, to what you just said, we have all these nociceptors on the skin. Radial is generally known to be more painful because to get at depth, you really need to crank it up. And especially if someone has lateral epicondylitis or something that's chronic and painful, the radial is just going to have a little bit more intense pain because of what's happening at the surface, because the strongest energy is hitting the surface and spreading out, whereas focal isn't really affecting the surface unless you stand it off to that point. So, deeper and more superficial, you have that effect. And so a little bit more painful, I would say most people would say the radial is, although you can crank up the focal to quite a painful degree. So, I think they both have their share of discomfort, but pain-wise, it may be, if something is sensitive and chronic, I think the radial may be a little bit more painful in that aspect.
Yeah, most definitely, because of where the nociception is occurring.
Mm-hmm.
Let's see. Let's go to some more questions here that Grove can answer. We got a lot of really good questions, actually. This is a new one. I have not heard this question before, but where do you place the Shockwave for migraines?
Well, you got to figure out, is it truly a migraine, first of all? I mean, there is no treatment protocol for migraines. The typical places that you're going to go to treat is in the suboccipitals, and you got a large blood flow there, a lot of nerves, and you've also got the brain. And we just don't treat over the brain, not with Shockwave. So in that case, but is it also coming from issues stemming from the shoulder? That's where.
Yeah, and is something coming, exactly, is there a lot of tension in the shoulders, and could that release actually solve the problem, right? And that sort of relates to another question that was asked. How do you feel about Shockwave over the cervical spine and neck region?
We use it all the time. And again, what are you hitting? Do you know your anatomy precise enough to avoid trouble? Just like if I have my fingers in somebody's neck and I'm trying to get to the longest coli on the neck, can I effectively avoid things like carotid and compressing nerves and such like that? If you know what you're doing, you can. But Shockwave, you've got to shoot through all of that. So you can't do things from the front, you got to do things from the back. And do you know what you're actually hitting? Are you being specific with your treatment? If so, between muscular tissue and getting down around the zygapophyseal joints and such like that, you can still treat pretty effectively in that area. But if you're not confident, don't go there.
Exactly. Right. Know your anatomy.
Yeah.
Right. And know the depth of that anatomy on that particular patient.
Well, then also know the technology you're using, right? You probably wouldn't use radial directly over spine, whereas focal, you're a little more confident with that use.
Yeah, I don't know.
What would you do in that case?
I think Alex uses radial constantly for paraspinal. I do know a couple of doctors who've used radial for cervical area. If you do it in the wrong spot, the patient will have tinnitus for a stint.
Yeah, definitely. And there is some, I get good effect even at not so much subsensory, but sub pain. If I get somebody in there that's fibromyalgic, I still can get good results without causing immense amount of discomfort.
Right.
Okay.
Jeff, you want to read the one about kinetic change? That's actually a very good question.
Yeah. What are the parameters for kinetic chain?
Well, I mean, kinetic chain is you have to be aware and understanding that. It's like the 15-year-old soccer player with bilateral shin splints problem. That was not a muscle itself problem. What was driving the problem was his kinetic chain. It was his tibial rotation. It was foot control. It was upstream into his low back and pelvis. As we were able to reduce the amount of pain, it opened up the opportunities to improve his kinetic chain, improve movement, strength, flexibility, and all of those things. And Alex is very good at touching on the reflexive points of the kinetic chain as well, and that's where you can utilize Shockwave like you can Washaw, trigger point, and such like that in order to affect the kinetic chain and get instantaneous results in a very broad aspect of the body.
Right, such as treating an ankle and releasing tension in a shoulder, making a patient already feel better at that point, and then of course treating the shoulder issue after that, right?
Most definitely.
Great question here. James Christensen asked, any concern about using it for a calcified nuchal ligament?
Calcified nuchal ligament. That's really interesting. I mean, the problem with calcified ligaments, tendons, and such like that is that you really need high amounts of energy to affect change. And you're already in an area where you're susceptible to vulnerable tissues like neural tissue, blood vessels, and such like that. Could you go to a 0 or a 5 millimeter? Yes, but like with the focal, that shock wave that's being induced at 5 millimeters is still going to travel another potentially 30 millimeters. So again, what are you treating over? Nuchal ligament is a little bit problematic. You got to be careful with that.
Okay, excellent.
Good
Word
comment.
of caution there. Let's see. I'll answer this one. This is an easy one. Nicole Poe, how do you control the amount of shocks you deliver? How much time in between each shock? So Nicole, on a Shockwave device, you have what's called frequency, and frequency is basically, we can call it time of shock delivery. Basically, the more frequency, the higher the hertz, the faster the pulses will go. So if we're at a 1 hertz setting, it might be like this: tick, tick, tick. And if we go to 20, it might be like this: tick, 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 tick. So you have this very quick repetition when you're at higher frequency, and you have obviously the lower frequency you go, you have this much slower repetition. So a treatment of 2,000 shocks at a hertz, a frequency of 5, might take about 20 minutes, where that same treatment at a frequency of 12 or 14 might take 5 minutes. So really, you adjust this on the machine very easily by simply pressing a button back and forth. So, and that generally is based on patient comfort and how many pulses you have to do within your treatment.
Right.
And let's give Grove another good question here. I think
one more good one here.
Let's see. We can answer those, so we'll let Grove answer. I think you kind of already answered this before. So what is the maximum number of sessions for one body area that you are offering to a patient? And I think that's going to be obviously related to the actual treatment. And that same person said, if a patient has 5 areas that need Shockwave, for example, can all of those areas be treated on the same day? I believe that we answered. The answer was yes. Even if it's a bilateral condition. But what is the maximum number of sessions for one body area that you're offering to a patient?
As long as I see progress, I'll continue to offer the modality. If I don't see progress, that's when treatment stops and my diagnosis has to be better, right? Because obviously I've missed something in that.
Right.
It could be, again, that elbow pain is really, rotator cuff referral pain, and I did not do a good job of my diagnostic. So if I'm not getting a result within 2-3 visits, I'm reassessing.
And up front, I mean, I think in general, if you're talking to a patient, you're generally talking in terms of 5 to 6 treatments are usually going to solve most things. Obviously, if it's bone non-union or something like that, you're going to probably tell them. But in general, if it's a tendon ligamentous or osteoarthritic, I generally think probably you're going to say 5 or 6 treatments, right? And then if more are needed, we will assess it at that point, right?
Yes.
Okay.
Right. And kind of to wrap up on that, and it kind of puts the frequency question to rest also. But the question there was, go back to the question.
Which one?
It was at the bottom.
The bottom?
Yeah, there we go. Is there a specific frequency that gives better results? So essentially, the question is, which frequency gives better results? If it's high, medium, low, are you going slower, faster? Does it make a difference, or is it going to be dependent on body part, or how do you make that determination?
So I'm always starting slow in the beginning, so slower, lower frequency, because there's an education phase. I have to educate the patient on how to give me feedback, because this is really a partner thing. I can't just go after it. I need to teach them how to give me feedback so we can dial it in to the location as well as to their tolerance. If I have for example, if I have a runner in there that has plantar fasciitis and he needs to run today or wants to run as soon as possible, and he's had this for a while, he wants results quick, I can turn it up, both power and frequency, very quickly, but after that education phase first. So that's my first visit. So my frequency is low. And then after that, again, it really goes to the patient's tolerance more so than anything else on the frequency. Because I'll just use, for example, on the piezo wave 16, which is 2 steps down from the maximum amount of power on the piezo wave, if I run it at a 4 or 5 frequency, it's very tolerable. But if I go up to 8, it's not, because the energy density that's coming in at one time is just much greater. So I have multiple ways to affect the outcome, the subjective component, using frequency as well as power. But then also, it's also efficiency within the clinic. How much am I treating on this patient? And do I have more patients coming in and such? It does not seem to matter the frequency much to the result of a positive result of the outcome for the patient.
Yeah, and I'd like to comment on the scientific aspect of that. In properly made devices, and this is where Alex's study spoke about, that study in Europe in regards to the radial device, where frequency affected one device severely, and the energy output dropped off with an increase of frequency over 3 hertz, which is very slow. So that device's design was faulty, and the faster you went with the device, the less energy that came out. However, with properly made devices, and for instance, the EMS Doller class, which was the other device in that study, it was a Storrs deactor and an EMS Doller class. The Storrs deactor, unfortunately, when the frequency increased past 3, it just dropped down to almost the equivalent of 1 bar, whereas the EMS stayed above that level, actually stayed quite good, and only started to drop off at 20 hertz, which is very fast. To the credit of the piezo wave device, when you go past the energy level of 16 and you go to 17 and 18, the device will drop the speed down. The hertz will be dropped down by the device itself, because they want to make sure the energy that is wanted is being put out. And so they understand through testing that the device, once you go to the highest level and you want to keep that same millijoule per millimeter squared intensity, the hertz drops down, I believe, only to an allowable, is it a 6? I think it's 6 hertz. Whereas the other energy levels that are lower can be up to 8 hertz. So the machine itself, the manufacturers, instead of just not telling anyone and leaving that to be so that you think you're getting energy when you're not, to the credit of Wolf Elevation, the piezo wave device will actually bump down the frequency so that the proper energy is being let out. I can tell you, there are many other devices being sold that do not do that do not put out the proper energy levels. Even some of the most expensive devices on the market, which are unfocused shockwave devices, they're not even focused. The highest level of energy that they're capable of putting out is the equivalent of 0.04 millijoules per millimeter squared at their highest setting. Their highest setting is lower than the lowest setting on a real shockwave device. So these things need to be examined when you're looking at shockwave devices, which is obviously what we do. We do it with ultrasound, we do it with C-arms, we do it with orthobiologics, and we do it with shockwave devices. Unfortunately, most providers don't have the time to do that, and they have a lot of marketing people telling them how great some of these devices are, and some of them are extremely expensive. They only last 100,000 shocks, and then you have to replace the coil, the spark plug, whereas the real devices are warranted to 5 million shocks and lasting to 10 million shocks. So that not to go off on a rant, but that really needs to be clarified, because, and of course now that question came up earlier, whereas, and I know Grove will agree with this. Where is that one? What machines do you recommend? And we try to be as unbiased as possible here, but I would say, hands down, what we've seen through the people who've conducted studies, published hundreds of studies in Korea and Europe, and the users and the teachers that we all work with, the EMS Doller class radial device, which is why we sell it, and the Wolf piezo wave focal device, again, why we sell it, because those devices offer the highest energy levels, the best, longest longevity of the disposable. The Doller class radial, the cartridges are warranted to 1 million. They last to, we had someone the other day send us a picture of 3.7 million pulses. And the piezo wave, the 2 hand pieces are warranted to 5 million pulses a piece. And we see doctors at 12 million pulses and going. Whereas the other machines, which are triple the price, are 100,000 pulses. And this is why providers are actually treating their patients with 750 pulses. So hardly any energy coming out, and then hardly any dose of that energy. This leads to almost zero efficacy. I mean, you might as well be using a Theragun at that point, or a heating blanket, right? I hate to be a jerk and say that, but this is just transparency and truth. So it's really important for providers to get down and dirty and understand the science behind the machines, really check, look at the FDA website for the submission and see the energy levels in depth. Like one of those $90,000 devices that claims to be doing something, 0.04 millijoules per millimeter squared. They claim they go to 12 centimeters. Look on the FDA submission, you see 3.7 centimeters. And these are unfocused devices that are showing doctors focal studies and claiming they're a focal device. And this is why we have providers who worked with those machines for 2-3 years, didn't get the results that they wanted, and now they're using real focal devices and radial devices that actually put out the proper level of energy that creates, again, cavitation. Very important, cavitation. Look it up if you don't know what it means, but get to know that term, because that is why Shockwave is functional. So to answer those questions there, and I'm sure Grove probably has an opinion on, he's probably utilized a number of devices and can state what he feels about Shockwave.
Yeah, I mean, my operating principle in my clinic is being use precise technique to get precise results, and that's what differentiates my clinic from a lot of clinics. And so if I can't get precise application, it's not going to be as useful to me. That's my differentiator. And so the focal device allows me to, because it's a specific. It can target specifically, it gets specific results, and it's extremely, extremely reliable. And from the standpoint of investment, it's cheap to run, very little in the way of downtime ever. I have to clean the heads. And I just replaced my treatment heads here just about 2 months ago or so. My previous ones, I have near 30 million pulses between the two that I had before, and less than 20% degradation of performance. So I was still able to provide effective treatment for a long time. And now that I have the new treatment heads, it's nice.
And
know that I'm not going to have to deal with it for a while.
Right, 30 million.
And obviously,
That's
I know you're
impressive.
talking about the piezo wave just from me saying that. To be fair, in the focal realm, as far as we're concerned with the testing that we've done, there are two legitimate devices. There is the Wolf piezo wave, and there is the Storz duolith. And those devices are actually putting out the energy that's required for efficacy. There are many other devices out there. I'm not going to say their names. You guys can email me. We can discuss it. But they are not putting out the energy. They're not really legit. And to be fair, in our personal preference, the reason I like the piezo wave over the Storz device is because longevity of the device. You're talking 1 million pulses compared to 10 million pulses. And we're talking about two handpieces, one that treats a pinpoint area, which both the Storz and duolith have. And then, of course, Storz does not have the linear head that the piezo wave has, which treats a much larger area with focal shockwave. So that's what our preference is there. And of course, also, I think the piezo wave is a little bit more cost effective, not just because of the warranty, but also just on the upfront price. So for us, those are the two best devices. This is the Korean study publishers agreed. Most of the guys we talked to from Europe who published studies who used multiple devices felt the same way. But as far as real focal devices, it's going to be Storz duolith and piezo wave. And again, I think piezo wave is just our preferred device. And when it comes to radial, literally the only radial device that we've seen that's putting out the proper energy is the EMS Doller class, which is the original designer. And you can see when you take the devices apart and you see the engineering of just a hollow tube with a projectile, which so many of these Alibaba devices have and everything else. The problem is when you turn the frequency up, the positive pressure in those chambers is building up. And the faster you go, the more positive pressure builds up because the air has nowhere to go. And then it's basically stopping the projectile, the kinetic energy from striking the anvil as hard as it would have and passing that energy on. So, if with the EMS Doller class, you have this cartridge with the decompression chamber, air is moving out of the way, everything is flowing smoothly. So you get this literally level of 0.1 millijoule, put to 0.14, I think that comparative study even showed. That's pretty high energy for a radial device. Again, you got to be careful. And if you really want your treatments to be efficacious, you should really understand the science, because a lot of these companies are making claims. Unfortunately, I feel like they're ruining the shockwave field in America by flooding it with a bunch of marketing garbage versus actual science. And we saw the same thing happen with PRP. This is why we have hematology analyzers and we test everything. It's not easy to test Shockwave devices. We're actually working on getting a hydrophone to test output of all the devices, but there are submissions that had to be turned into the FDA, and they are required to report their actual outputs. And when you look into those, you start to realize, wow, that's not what the salesperson told me at all. And of course, feeling isn't so objective, but when you don't feel the energy from a Shockwave device, it's because it's not really doing anything. I mean, Shockwave is going to be painful. Activation of substance P is what happens. So when you have a company saying, our device is so great, even on the highest setting, you don't feel anything at all, that's literally an advertisement for one of these devices that cost $70,000. Run the other way. So,
Okay.
that is not a legit device. So again, and that's why we're here. Again, we're trying to be as unbiased as possible. Obviously, we'll probably be at the ASMST coming up this year. A lot of great people, Bryce Blatz, Rob Monaco. And again, those guys want as much unbiased science as possible. Obviously, there'll be a lot of companies there. But again, do your homework, right? Test devices, feel them out. Don't just believe sales reps. And there's a lot of companies out there, I hate to say it, giving kickbacks to people to get their other doctors to buy devices. And that's because they have no science behind their devices, unfortunately. And so we really need to address that, right?
Yep. So, but Grove, we really appreciated you joining us this evening and taking the time to go into depth and talk about your clinical experience and science of Shockwave. And just a quick shout out here, because you will be with us coming up November 7th and 8th. Come and visit. Definitely log in there and get registered for that Shockwave. It's going to be a lot of fun. Each one is. But again, thank you very much.
Beautiful sunny South Florida. Do me a favor, please bring me a jar of Colorado snow. I'm pretty sure by November 7th.
Not yet.
There's no snow there. But yeah, man, we're really looking forward to seeing you. The students, again, every time, I think we've had 2 so far that you've been a teacher at, correct?
Yep.
And all the students are just like, that was mind blowing. I mean, so we're really stoked and we're excited to have you here. And again, thank you for all your kindness and knowledge. You and Alex are both amazing, and we just love having you here, even without that. But the fact that you guys are such wonderful, humble people, and then Einsteins of the medicine world, it's wonderful. So
it's fun to share.
Yeah.
All right. Awesome. All right. Thank you very much. And we'll see you here in November.
Did we get everyone's questions?
He's got to go.
Yeah, no, Grove, thank you. We'll let you go and we'll dig into if anybody has any final questions, we'll answer.
Thank you guys.
We'll
Have a good night.
Grove
You too.
Alex. Thanks, Al. Thanks,
care.
Grove.
All right.
Let's see. So let's check our questions. If anyone else has any questions, I think we answered them all. Thank you everyone for being here. Obviously, again, the workshop is November 7th and 8th here in Sunrise, Florida. We are 20 minutes down from Fort Lauderdale Airport. It's beautiful here. When we have a great time, there'll be wonderful food, all kinds of great friends and family happening and people hanging out. But most importantly, hands-on Shockwave learning protocols. Again, Grove Higgins, you just saw from Neuroathlete in Colorado, will be here. Alexander Oblas from Germany will be here. Ashley Campbell from TOA in Nashville will be here. Ken Johnson from Johns Hopkins will be here. Perry Camissa from Ultimate Chirocare in Chicago will be here. These people will all be here teaching. Guy Puvendran also, my gosh, don't forget Guy Puvendran. Guy Puvendran will also be here. These guys will all be talking about Shockwave. Guy will actually be talking about the adjunctive use of shockwave and regenerative medicine together. So again, amazing protocols, hands-on. You will get to treat patients. You'll also get treated if you need to by the experts, and it will be an amazing time. This will be recorded, and we will be sharing it with everyone via email afterwards. You'll get an email giving you the access. Again, please feel free to email us at any time. Do we have our email addresses anywhere on anything? Well, info, where's that slide? There we go. Info at regentixmedical.com, or
well, you can get to me, Jeff Rubinoff at iradsales.net. Very simple. It's very great. That's it. So definitely we'll see you here in November if you're going to be here in November. If you have any questions, send an email, but you will have access to this ongoing to rewatch. So.
And anatomylab.com. In January, we have sexual wellness workshop with Ann Trong. Again, going to be 2 amazing days on female and male sexual wellness. Shockwave will be in there. Orthobiologics will be in there. And then, of course, coming next year, we will have lots and lots of cadaver ultrasound injection courses, orthobiologic, bone marrow aspiration, microfat, and many, many more Shockwave courses and other great trainings for you guys. Thank you, everyone. We will see you again soon. Have a great night. Thank you.
Right now, just based off this being get everybody.
Okay, everyone.